Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our symposium series. I also want to take this opportunity to thank all of you who have become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
Good afternoon, and welcome to our session on Mythbusters regarding pneumatic compression devices and their role in successfully managing lymphatic and vascular disease. I'm Cheri Hoskins. I have actually been treating patients for over 30 years now in compression therapy. I've had clinics all over the United States, MLD clinics that combine pneumatic compression with treatment of lymphedema. I also have lymphedema, so I'm not only a patient, but the reason that I got into this is because I had a mother that had lymphedema and died when I was 14 years old. My lymphedema didn't occur until 15 years into treating patients, and it was the result of lymph node removal from my left lower extremity. So let's talk today about our supporters. They are what keeps this organization going. LE&RN, which is Lymphedema Education and Research Network, counts on these supporters in order to bring these types of information to you, symposiums. And they do a great job of that. We'd like to thank those supporters. I have in front of you right now a disclaimer by LE&RN, and you can read this at your leisure. It's always up on the website, and it is something that is available to you at any time. What we're looking at today as far as objectives is, how do you know the difference between science and myths? Do your research and be your own advocate. In this day and time, we actually have no patient advocates except for us, the people that are out there advocating like LE&RN to bring you information. So you have to really take care of yourselves, take care of your parents, take care of your children. Get involved. That's the best thing that you can do, is get involved and help and educate as much as you can. So when we talk about lymphedema myths, many myths exist within the community of lymphedema treatment. And as therapists, we're taught certain things. It's drilled into our heads. With me, I have to have science. And I'm one of those boring people that goes to bed at night reading papers on different treatments and the outcomes. Let's talk about pneumatic compression and the differences between pneumatic compression devices. You have non-peristaltic devices, which are like bandaging. You hold pressure distally. If you're working on an arm, then that means that you're going to hold pressure at the hand. And as you move up, the pressure gets lighter. But you never release that pressure at the hand because we're afraid of backflow, which can occur, and that hand would swell. So the holding pressure as you move up creates like a plumbing system. When you look at your house and how it's built, you have pipes under your house, and when you turn the faucet on in your kitchen, it creates pressure under your home in order to bring water at the significant pressure into your sink based on your adjustment to the faucet. And that's the same way a non-peristaltic action works. A peristaltic action, and you have pneumatic compression devices with that, releases pressure distally as you move up. So you have pressure at the hand or the foot, and then the next chamber fills. And when that happens, the chamber at the foot releases. And in those cases, my experience has been that there is backflow into that area. We look at the billing codes for these devices, and you see an E0651 pneumatic compression device, which is a non-calibrated device. The difference between that and an E0652 pump is the fact that the E0652 pump is calibrated, meaning that we can adjust the pressure in any given chamber. When would you need that? You would need that when you have a patient that has contractures, somebody that has a contracture at the elbow, contracture at the knee, and the limb will not straighten out. You don't want to put pressure on that because when you do, it's painful. So you want to release the pressure over those areas. We all get bruises. We don't want to put compression over that. So therefore, we could release the pressure over the bruised area and anything that is proximal or above that in order to continue treatment. Otherwise, the patient would have to stop treating their lymphedema and chance exacerbating over the 1 to 2 weeks until the bruise heals. In my opinion, every patient should have that ability to change the pressure, but Medicare doesn't agree with me. Then we have painful scarring or scar tissue. And you would want to release the pressure over that. Or a painful wound. Sometimes patients have wounds, and they're generated based on the fact that they have lymphedema, and we might have to release the pressure over that area. Another myth that we're taught is that pneumatic compression causes genital edema. Well, that's simply not true. We did a literature review, and I've been on the board of directors for many different organizations, the National Lymphedema Network, the American Society of Lymphology, and we've all done these reviews in literature. Unfortunately, there's not a whole lot of data. What we found was that there was less than 4% of the patient population that was recorded that had genital edema. Out of that 4%, 57% of those patients never had a pump. 43% may have had some sort of lymphedema treatment. Then I went to Dr. Olszewski because we couldn't find any science. And Dr. Olszewski is a world-renowned lymphologist out of Poland who studies the lymphatics on a regular basis. And I said, how can we prove this? So he said, we have to do a lymphoscintigraphy on this patient that we're getting ready to treat, and we have to remove a lipoma. So what I'm going to do is I'm going to put the isotope, which is dye, and it's radioactive, into the lymphatic system, and I'm going to image it through MRI before I place the patient on a pump. And after this is the before picture on your left-hand side. After I do that, then I'm going to do another MRI and see where the channels are and see if we have flow and see if it goes up past the inguinal area or the groin And he did that. And what we see on the right-hand side is the flow of lymphatic fluid all the way up past the inguinal area, up into the femoral passage, to be reabsorbed back into the tissue in the abdominal area. That's what our bodies would normally do. With pneumatic compression, we can't fix the lymphatics. Once they're damaged, they're damaged. There is no treatment, there's no medication, there's nothing we can do. But with pneumatic compression, what we can do is externally replace the lymphatic system with pneumatic compression. And pneumatic compression in a non-peristaltic action is 3 modalities of treatment. You're actually not only just providing that external use, you're providing MLD, the light touch massage, you're providing exercise, and combined with bandaging. So for an hour of treatment with pneumatic compression, you've gotten probably about 4 hours of treatment otherwise. Now, if you stopped using pneumatic compression, you would be back on the left-hand side of this picture because you're replacing the lymphatics with pneumatic compression. This is a better picture of what you're seeing. And this is called lymphoscintigraphy. So if you're a patient logging into this presentation, this is what your doctor's looking at. Again, I give you Dr. Olszewski's credentials. You can actually look him up. He is authored in 22 different textbooks and documentation on lymphology. Now we know that evidence clearly shows new channels formed using a non-peristaltic action where you could see isotopes all the way up through the femoral passage, bypassing any damaged inguinal nodes or damaged nodes in the genital area. And remember, once the lymphatics are damaged, I can't stress this enough, they are non-functional and non-repairable. What we're doing with pneumatic compression is providing an external mechanical replacement for them. Another myth that we're taught is that pneumatic compression should not be used in conjunction with complete decongestive physiotherapy. Well, Dr. Roxon, who has spoken on one of the symposiums earlier, had a clinic at Stanford University, and his therapist told him and Dr. Shuba that they could not use pneumatic compression on their patients in conjunction with therapy. So Dr. Roxon and Dr. Shuba decided that they were going to do a study because they couldn't find any science that proved that. And it was published in the Cancer Journal in 2002. And what they did was they took a group of patients and they did nothing but an hour MLD, the normal complete decongestive physiotherapy program, an hour of manual lymph drainage with bandaging, and then they took another group and they did half an hour of manual lymph drainage and half an hour pumping. And what they found was pretty good on the side of manual lymph drainage, but it's not what their therapist told them, because the patients that had a pump in conjunction with manual lymph drainage received about 45% reduction. Those with bandaging and MLD received 25% reduction. So they said, okay, we are going to send these patients home on a home program and see how well they do there. We're going to discharge them from our outpatient facility. We're still going to monitor their data. And we're going to take the pump away from the patients that had a pump during therapy, and we're going to give a pump to the patients that did not have a pump during therapy. We're going to monitor them, and after a period of time, they collected the data. What they found is that the patients that had no pump in their outpatient program actually increased in size by 32.7%. Those patients that had a non-peristaltic pump continued to reduce in size by 89.5%. So what we know is that pneumatic compression, based on the study that we just reviewed, is important both in the treatment and maintenance of lymphedema. And pneumatic compression does improve the results of manual lymph drainage, or a CDP, congestive decongestive physiotherapy program, over a period of time. And it's the only therapy available in some rural areas, or areas to where the patient cannot get into therapy because they're homebound. The treatment was well tolerated in the study, and there were no adverse events that occurred. Another myth that we're taught is that pneumatic compression does not move protein, it just moves water. I'm sorry, but I had to really laugh at this, because tissue fluid, where the lymphatics flow, we're made up of over 70% tissue fluid. Our bodies are. The only way to separate tissue fluid is through, if you had a built-in centrifuge, in order to spin it down, separate it. But there was still no science to prove that, and I went back to Dr. Olszewski and I said, can you help me with this one? I'm trying to find out the truth. And he said, this is what I'm going to do. I have a patient that has a lipoma, which is a huge growth off of their lower extremity that collects lymphatic fluid. Sometimes you might hear it be referred to as a fatty tumor, and it has to be removed. So he made his incision, he inserted wool into the tissue to absorb the fluid. And the fluid, or the wool, was sent to the lab to measure the protein and water. They spun it down, and then he put the patient on a pump. And after 30 minutes, he stopped, put wool back into the tissue, and sent it back to the lab. The concentration was the same. Had you moved more water than protein, the protein levels would have been much higher and the water levels much lower. That did not occur. Another myth that we're taught is that pneumatic compression is not effective without pre-clearing or stretching of the skin. As therapists, what we do is, for instance, if you're looking at legs, we're going to work the abdomen area in order to make room for fluid to flow from the legs up into past the femoral passage, or into the femoral passage, to be reabsorbed back into the tissue. If you have a non-peristaltic pump, remember, what we're doing is we're working on force distally, and we're actually using that force to create movement up through the femoral passage. So body fluid movement, when you're using pneumatic compression, is based on distal to proximal pressure, holding pressure distally as proximal action occurs. Once pressure is released from the body, fluid returns unless new channels are created, which occurs through that distal to proximal action, just like bandaging. That's how bandaging works. Another myth that we're taught is that pneumatic compression should not be used on patients with lymphedema and wounds. We know that's not true. And there's been science over the time that showed that. But we were at a meeting with Medicare not too long ago, and they said, look, we're not going to look at anything that is over 10 years old. So we looked at the fact that venous stasis ulcers account for 80% of all lower extremity ulcerations, and that they're more common in women and older age patients than anybody else. And they usually reoccur and can persist from weeks to many years. Ulcers will not heal if you have lymphatic fluid surrounding them. Ulcers breed off of bacteria. Your lymphatic system is the filter from your venous system. And when it filters out through the lymphatic system, if you have a normal one, what is supposed to occur is it filters the bad stuff, goes out through the bowels or the kidneys, and the good stuff goes back into the venous system. When it's compromised, that doesn't happen, so it settles into an extremity. And because it is bacteria-ridden and it's the trash from your venous system, if you acquire a wound, which is possible due to the problem with the lymphatic fluid, it won't heal. The severe complications from this, of course, is cellulitis, severe dermatitis, wound pain, osteomyelitis, and malignant changes. The cornerstone for treatment, as said before, has always been compression therapy with pneumatic compression. But Dr. Alvarez out of the Bronx and New York, who had a palliative care center, did a study in order to refresh what we had out there, to show healing in patients that had venous ulcers and secondary lymphedema. So he took 52 different patients that had that and did this study over a 9-month period of time. These patients had these ulcers for a year or more. He had a control group that he did nothing but traditional wound care and then compression bandaging. And then he had a pneumatic compression device group and a leg garment plus traditional wound care. What he found, and he used a protocol of 50 millimeters, distal pressure, an hour twice a day. And when we talk about pressure settings, we're always talking about setting a pneumatic compression device at the greatest pressure distally, and then as it moves up, the pressure gets lighter. What he found in this study is that the patients that had a pump actually healed almost twice as fast as those patients that did not. Their pain scores were significantly lower, and that pneumatic compression continues to be a valuable adjunct in the management of these patients with large painful wounds and secondary lymphedema. Well, he wanted to take it a little bit further because he was in, or is in New York, in the Bronx. He had a very poor population. The weather was not conducive a lot of times for them to get into treatment. So he talked to Dr. Lulev, who was in Boca Raton, Florida. Beautiful area. 80 degrees year-round, golf community. And he said, look, can we do a study to see if any of this, the demographics, have any result on treatment for these patients with secondary lymphedema who have venous stasis ulcers? And they took 94 patients and treated them in these 2 independent specialty centers, and they did a study over a 12-week period of time. Now, in Boca Raton, Dr. Lulev said, look, my patients, they're used to golfing. So what I'm going to do is I'm going to give them that freedom, and my protocol is going to be 50 millimeters of compression, 45 minutes to an hour a day for 5 days. I'm going to give them 2 days off to go golf. because I want them to be compliant. If I don't do that, they probably won't be. But in New York, Dr. Alvarez stuck with his protocol, 55 millimeters distal pressure an hour twice a day, every day. What's interesting is the conclusion was the same in both centers. The incidence of healing was 80% over 12 weeks. Their pain scores were significantly reduced as the prior study that we talked about, and their edema was significantly reduced over that period of time. Patients kept the pumps, they're still being followed, and we're thankful for that. So when we talk about pneumatic compression, we're talking about gradient sequential multi-chambered pumps, and the patients must be trained in their use because they use them at home, and they usually use them 1 to 2 hours a day. They're absolutely essential for long-term care. They provide quality of life to patients, independence, and they save benefit dollars. Because when they get a pump, it's a purchased item. They use it for lifetime. They don't have to necessarily go back through treatment over and over again. So it prevents revolving door treatment. If it goes untreated, we know that you've got a cycle of fibrotic tissue, which is the hardening of the tissue. It's more difficult to be able to treat, and it's more injurious to the tissue, causing malformations. Then you have that progressive worsening and swelling and incidence of infection. These patients are so susceptible to infections because it is the trash from the venous system. It's full of bacteria. So in conclusion, we really want to ask you to please, or I do, please get involved. Support the programs such as Lymphedema Education and Research Network to help others involved in your care. Talk to your therapist and other patients. I've given you my contact information here that you can contact me, or you can go through LE&RN. I'm on Ask the Expert, and you can reach out to them and ask them any question whatsoever.